managing cancer in older people. Thank you for joining us. Thank you for keeping time. Maybe you can quickly send a reminder to your colleagues to join us so that we can start together. We are just testing the screen sharing for Dr. Njiraine. There it is. And we can confirm that that's good. Kindly confirm that you can hear me well. Charles?
We can hear you well.
Excellent. Thank you very much. So, thank you, Njoki. Welcome. Dr. Andrew, as soon as you're ready, we can test your screen sharing, and I will just give a brief background on cancer and aging and why this webinar. This webinar is part of a series of 4 webinars that we have planned. Actually, I should begin by introducing myself. My name is Dr. Bor Paula Malenya, and I work with the National Cancer Control Program. I'm passionate about controlling and preventing non-communicable diseases, including cancer. I also have a liking or an affinity for older people, and so the webinar that we have is something that I'm really looking forward to as well. This webinar has been organized by KenCox, a network of cancer organizations, in collaboration with the National Cancer Control Program. And you may be wondering why cancer in older people. I would like you to just write quickly in the chat, how common do you think cancer is in older people, like in terms of out of 100,000? Older people, I think, are defined as people age 60 years and above, although this might be debatable. But I would like you to write, out of 100,000 people, how many, how frequent do you think cancer is in the older people? I'll tell you the incidence rates among people below age 20 is 25 per 100,000. In people aged 45 to 49, it's 350 per 100,000. And in people above 60 years, what do you think? Let me see some. Just write in the chat a number. Do you think that could be the number of people above 60 years who, the incidence of cancer in people older than 60 years? What do you think? I've told you that in less than 20 years old, it's 25 per 100,000, 25 cases per 100,000. It rises. 45 to 49 years, it's 350 per 100,000. What do you think the incidence is among people older than 60 years per 100,000? Farheen, 200. Nasim, 550. Njoki, 600. Any other guesses? Feel free to write a number. Any other guesses? So from the guesses that you have put in the chat, I'll tell you that you are halfway there. It's actually more than 1,000 per 100,000. And globally, more than half of the people who have cancer and more than 55% of those who die from cancer are over 65 years old. You know that our population in Africa is relatively younger, and the picture is changing as we are transitioning in our population. And you find that our median population in Kenya, for example, has risen from 15 years in 1980 to 20 years in 2021, and it is projected to rise to 28 years by 2050. So this points to an aging population. And so there's need to prepare ourselves in the limited time period to prepare policies and the health system to respond adequately to deal with health issues among the older people. And these older people, guess who they will be? They will probably be you and me, isn't it? Okay, so I would like to request us, I would just like to inform you that this is part of a series of 4 webinars. The first one we held last week was on cancer prevention among older people. This week, it's on managing older people living with cancer, so issues around treatment. Next week, we will have on 11th November at 3 p.m. It will be on palliative care and end-of-life care, both from a policy perspective and also the legal issues around palliative care. And then the week after that, it will be on communication and counseling skills for use with older cancer patients, including psychosocial and cognitive issues and effective communication with older patients. So we look forward to joining us, and tell a friend to also join. So without any matter ado, I'd like to introduce our webinar speakers for this evening. Our webinar speakers are Dr. Andrew Odhiambo and Dr. Njoki Njiraini. I'll begin by introducing Dr. Njoki Njiraini. Dr. Njoki. Dr. Njoki is a consultant clinical oncologist here in Nairobi, Kenya. She is based, she has been key instituting multidisciplinary team meetings with KNH, that is Kenyatta National Hospital, KU, Teaching, Research and Referral Hospital, and also at the Nairobi Hospital. She has also been key in instituting problem-oriented research and streamlining patient care within the oncology clinics. She has been part of the team that has developed various oncology guidelines in Kenya. She holds a bachelor's degree in medicine and surgery from the University of Nairobi, and also a master's degree in radiation oncology from the University of Cape Town. She is a fellow of the College of Radiation Oncology of South Africa. So I will welcome Dr. Njoki. And before I do that, let me just remind us a few housekeeping issues so that we are sure that we work well together. I would like to request us that we mute our mics at all times. I would like to request us also that we keep our cameras because of 2 reasons. One, sometimes they are very distracting, and secondly, for better internet reception, especially for our colleagues joining us from Mashinani, I'll request the speakers to turn on their microphones briefly or as long as they are able, and then we'll let us use the chat box so that we can ask any questions we have or make any comments as we go along. And then I hope we will all have a good time together. So allow me then to welcome Dr. Njoki, and she's already sharing us. Karibu, Dr. Njoki.
Good evening, everyone, and thank you for this opportunity. I'll also turn off my video. At least you can see me. I am here, so that we can discuss it. And I think it's a pertinent topic that we need to talk about. So I don't have anything to disclose. And just an outline of what we'll go through, a few definitions, what's our current outline, what is this geriatric oncology, why is it important, what are some of the considerations, and we look at a case report on one of the patients that we've been able to manage. So if you Google or look at any publication, is that old age is defined as the later section of life, but then we need to have a definition of what that age is. According to the United Nations, anyone who's older than 65 years, but the WHO sometimes has different definitions, and I always find it's a problem, especially when you have research or publications that's coming out of Africa, where they say that old age is defined at 55 years. And I like the fact that JP started with a definition of what do we think is an older person. And in Africa, as we try and sort out all our issues with infectious diseases, accidents that are happening left, right, and center, is that our expected lifespan is actually shorter. If you look at the Kenyan ones, I think we are now looking at 58 years. Well, that being said, the rest of the world or globally, it's accepted that 65 would be what would be the definition of an old age or a person who's older. But what are these perks of aging when we think in terms of oncology is that as you grow older, your gene repair activity goes low, your number of mutations or your genetic instability increases, your fertility, of course, peaks and then goes down. And then, of course, the physical aspects that you usually find where people are aging. But this is important because at a certain point in time where you get a crossover of the reduction in your gene repair and your increase in the number of genetic instability or number of mutations, then predisposes these patients or our older population to having cancers. And this usually starts as pre-malignant conditions, after which that becomes invasive and that actually ends up leading to cancer. If you look at this, I think it's very well extrapolated in patients who have cancer of the colon, where you find something that would have started as something very sinister, dysplasia or changes on the lining of the colon, takes many years before you actually find that the patient has cancer. And of course, this compounded with other age-related problems like significant comorbidities ranging from diabetes, hypertension, hypercholesterolemia. You can see that that basically becomes a ticking time bomb. Now, there's no way of slowing down this process of aging. I think all of us, as long as you're born, you will go through life and age. So what we're discussing here is, again, the increasing population of patients who are older, and they actually form a significant proportion of patients that we see in the oncology service. Now, when we think about patients, sorry, I have to close this. Patients who are elderly, is that about more than 70% of patients with cancer are actually 65 years and older. And I think there are quite a number of references looking at this. And of course, for patients, this again is in the US, that again, less than 25% of patients will be enrolled into any trial. And I think this is important because then we're dealing with a significant proportion of patients, but they don't actually form the people who we study many of the agents with. So if you were to be a purist, many of the agents that we'll be using are not in the select patients who form the bulk of the patients that we see. Thirdly, is that these patients, because they are elderly, they are more vulnerable to having issues of over-treatment or under-treatment. And we'll delve into the details of why this is important, because then patients, by assuming that they are older, they may not be able to tolerate a certain type of treatment. And finally, is that when we look at things like performance status, which is a significant part that we look at in oncology, where we say how fit is a patient for treatment, most of the assessments that we do will not accurately predict the performance status of a patient. So the commonly used ones are the Karnofsky performance score or the ECOG, which is the Eastern Cooperative Oncology Group scoring system. That does not in any way take into account what the age of the patient is. So a 20-year-old who's spending 50% of the day would get a performance status of 2, while an older man who is in his 80s, had a hip replaced 2 years ago, spends more than 50% of the time in bed, not because he's unwell, because of his hip, would still get the same performance status score. And I think that's important to sort of tease that out. So then if you look at data from the US, is that what is the expected life, life expectancy for both women and men? We know that women live longer than men, but as you see, as you age, then your percentage of life expectancy goes down from the age of where we say the cut of about 60, so this one looks at 70, all the way to 95. And I think this is important to keep at the back of our minds, that as we are talking to these patients about treatment, when you're talking to them about that this treatment is to improve your overall survival, there is a timeline of looking at that overall survival, and especially for patients who might have other comorbidities. Now, when I was going through this, is that we have to again think about, we have to think about how we are going to be communicating with our older patients. Again, they are not the typical me and you who are tech savvy. We're always on our phone. We think we can multitask. We must think about how these people are seeing us. They have issues with vision, so you may be there explaining many things, pointing out on scans, but they cannot be able to see that. Hearing again becomes a problem. And I find that this is one of the most underdiagnosed ailments that old people have, where when you go visit your grandmother, you have to shout and she may just need a hearing aid. We have to put that into the context that for some of our patients, they may not have been diagnosed to having a hearing issue. If we are giving them written information, and I find this on all the brochures, the text is written in small font, even I sometimes would struggle. So we need to write for them in bold text using bigger fonts, and most importantly, use pictures as much as possible to illustrate what we need to tell the patient, because this might be the material that they reference to, and they may not go through the prose that we go through. Allow me to delve a little bit into oral communication, and I know there's a section that we're going to look at in this webinar series about how we communicate. When we talk to any patient, especially older patients, we must avoid jargon. I sometimes feel like even talking about the word cancer, malignancy, metastasis, they may not understand what that is. So you have to break it down so that they understand that. You always have to communicate to the patient facing you, because as I said, if they have a hearing problem, they may be lip reading. So you need to actually be in full vision of the patient. You need to speak slowly, you need to speak clearly. Don't shout at them, because I think that is one of the most condescending things that can happen to someone who's mature. Maybe they were very highly functioning, they're an intelligent person. You don't have to shout to them because you're assuming that they can't hear. And one of the things that has been utilized is make sure that the wall is behind the patient, because that may help to amplify the sound for those who may have a problem with hearing. I think it's most important, after you explain something, that you pause at the end of your sentences and ask them if there are any questions, so that if we introduce a concept that, so you're going to go for a mammogram, after which we are going to, so you need to pause so that we are at the same page in terms of explaining, because I always feel we are fast. We are always fast, and we want to make sure that we get through our clinic, but these patients may need a little bit more time. Now, I've put there that we avoid elder speak. And elder speak is where now, because you're talking to your grandmother, you want to simplify it as much as possible, shout and speak slowly. Most older patients will find this very condescending, and they may form an attitude towards you as a clinician or the person who is talking to them, because it's like you're assuming they don't understand just because they're older. The teach back technique is where you go through a concept and you ask them, so Mr. Kamau, what did you understand by me saying X, Y, Z? And that's to gauge how much of the understanding they have, because it's quite unfortunate when these patients have seen 2-3 clinicians and they still tell you, I don't know what the doctor told me, because we didn't go through the process of trying to explain to them slightly differently from our younger populations that we see. So there is a concept called a comprehensive geriatric assessment. And this is where we have to assess these patients in terms of multiple factors. And if you look at this, we need to assess what is a functional status. I had touched on that. In terms of our assessment of performance status in our clinic, we do not take into consideration what's the functional status. What are the patient's comorbidities? And I think this is so important. It's not just a clinical question that we ask, what other medication are you on? I think for them, we have to go through that in great detail, because some of the comorbidities may dictate what treatment are we going to expose them to. Have they had diabetes for a while? Have they had hypercholesterolemia? Did they have a stroke? All those factors need to be considered. And in the same breath, remember, these patients will be on multiple drugs that they are using. So that polypharmacy also has to be taken into consideration. And here your pharmacology training comes into play, because that may not be the reserve of the physician or the oncologist to look at, that you will need a pharmacist who sits with them, because you may have a lot of drug interactions on the drugs that they are on, and plus the new medication that we're going to introduce from the oncology aspect. Their nutritional status. We find that majority of older patients, we actually reported to have higher rates of malnutrition that we used to see maybe in children before. And this is because your children are grown up, you're left alone in the village, you cannot prepare your food, or for one reason or another, you cannot afford quality food that you need. So they may need to actually have a nutritional assessment to also assess whether there's something that we can supplement for them before we start. Psychological issues are going to be there, and they may be dealing with issues of abandonment. They don't see their children. A lady has an ulcer on the breast. The children now show up and they want to do everything for their mother. That has to be dealt with. So that psychosocial support or psychosocial assessment may need to be done at the beginning, or where they say, I'm old and I've lived my life, I would like to die. There's something that maybe we need to delve in that may not be that a patient is refusing treatment. Cognitive function, and I think this is one of the most important, because you may find patients who have been having dementia, memory loss, they've come to the clinic alone. It's a gentleman who's brought, or a lady who's brought her husband, and in terms of cognitive function in terms of making a clinical decision or making a decision on what treatment they need to have might be an issue. So we also have to assess what their cognitive function is, whether they can make informed decisions. So otherwise, even talking to them for that long and they may not make a decision at the end. Socioeconomic status, I think it's important, especially in our country where the welfare or looking after older patients is not something that's mainstream. So you may need to find out who is paying the bills, who is supporting them when they come for treatment. And then we have geriatric syndromes. And these ones you may never pick up unless you sit in a geriatric clinic. So you may assume hapana pale, or they're having a metabolic syndrome, but someone has to sit down and figure out whether there are any of those syndromes that the patients may be having. But there's a caveat, is that there's no correct or single way of doing a comprehensive geriatric assessment. So it involves what setting are you working in? Is this patient in the hospital? Are they in the clinic? If they're in the clinic, you may not have that ample time of assessing the patient for such a long time that you can do that for 2 hours, go through the polypharmacy, do the cognitive, but you may have facets that may be outsourced from the clinic, or if they're in the ward, then that can be done at the same setting. Our models of care. So in the, when you think in the Western world where there is a geriatric clinic, if I get a patient who's more than 65 years old, I can quickly do a referral to a geriatric clinic, and then this CGA can be done by somebody who that is their specialty. It may not be the same, and we may not reproduce that in our setting because of our arrangement of our primary health care. Someone gets diagnosed with cancer, is referred to a cancer center. That cancer center has not had any infrastructure of assessing and managing the geriatric patients, which again form more than 60% of the patients we see in the oncology centers. We have to also be cognizant of what our capabilities, and I was saying in Kenya, people who are practicing geriatric medicine are physicians with interest, but people who've actually specialized in geriatric medicine are very few. They may be concentrated in the big cities, and again, the resources that we have to execute now the comprehensive geriatric assessment. And if you then think what this would entail from all the aspects that I've talked about, there'll be a medical history, which I think is what we take, and sometimes it's very short, very shallow. We don't even get all the details. It could be a physical assessment, functional assessment, behavioral, the emotional, which you say the psychosocial. Environmental might be together with social, like the socioeconomic, who's supporting them, who's not, and then the spiritual in terms of assessing what do they practice, which faith, what do they believe in? Do they believe in treatment? Do they want a transfusion? And all this needs to be factored in when you're assessing these patients, because you may think they're the most difficult patients to deal with. So I thought this was an interesting paper that I looked at, and it was looking at how we implement that multidisciplinary approach in older patients, especially in an oncology practice. And in this model is that they looked at the patient needs to be seen at the time of diagnosis. We talk about the toxicities, the hospitalization, you need to look at their units. And if you look at this, there are like 6 rooms that the patient needs to go through. Now, I don't think that there are any of our clinics that are set up like this, that the patient will go to audiometry so that we can figure out what's happening with their hearing, go to pharmacy, they look at all their drugs, get a nutritionist, go to physiotherapy, and then for counseling sort of towards the end. And this is to all look through on the various factors that we talked about, and then you get referral for these patients to either the oncologist or the primary care physician. Now, this interplay or this intricate system cannot, I don't know if we have reached that point where we can develop it, but we can have a formative stage of assessing these patients and integration of more cognitive geriatric assessment in our clinics. But then that being said, how do we do this? Is that number one, out of all the aspects that we are looking at, we have to look at what is called the self-reported function and mobility. And this is where I was saying we look at activities of daily life. All these guidelines or all these indexes are online. So if you were to Google them, you would actually find how to score the patients. What is their risk of having a fall? I think when the patient is in the ward, that's where we do more of the falls, but not as outpatient. Objective function and mobility. So this is where the patient reports their function and mobility and what is our objective assessment. Again, this is easier for some of the physios, they do this quite well, or the physical medicine unit. So they actually have tests to assess how fit the patient is in terms of mobility. And then they intervene in terms of, do they need a walker? Do we need to change where they live? What is the home safety for them? What is the required physical activity, or just telling them to walk while they have a bad knee and no crutch to walk? on. Again, is to refer them to a trained primary care physician or a geriatrician so that we can assess how to improve this for the patient. The second most important thing, I think, is assessment of comorbidities. And as I said, we usually assess this by saying you have diabetes, you have hypertension. There are some scores that we use. I think the Charlson Comorbidity Index is the one commonly used. And this can help you to predict what is the impact of someone having diabetes on their prognosis for cancer of the prostate. And then you get a life expectancy table, because when we are talking of a treatment that is radical, looking at overall survival of 10 years, then we have to know that this patient most probably will live for those 10 years. Otherwise, it's a moot point to discuss someone who has had a stroke, has had an MI, has hypercholesterolemia, is bound to a wheelchair, and we're talking of radical treatment, because then this patient will not live long to get the benefit of our expensive and radical treatment. Again, for patients who have lymphomas or leukemias, then we assess how much of their organ dysfunction they've had and then relapse mortality risk, and there's a score for that one. In terms of social functioning and support, and I think this is where most of the time we have not done very well, it's to assess what sort of engagement they have with physical or social activities. I find that for most elderly patients in Kenya, what they do is once you're too old to either go to the farm, nobody ever looks into how do I reintegrate exercise into your life. How do we look at your home like you don't get a fall in the shower? How do we assess that you're going to church or you have some sort of social interactions? Because patients can be quite isolated, especially for our elderly patients. Do they feel that they have emotional or informational support, or someone that the child or comes and tells them we have this cancer, we have to treat it, and there was no impact on how this is affecting our elderly patients? Again, how they feel that they have any tangible physical social support. You'll find most of the elderly patients live alone. So if it's a couple, they live just the two of them and nobody else. And that, of course, predisposes them to having other issues where nobody picks up that one of them is not doing well, and that becomes a problem. Again, our old age homes, there are very few. They're quite costly for some of them. So even when someone needs that extra care, they may need to actually be in hospital. Well, they may just need home-based care at the hospital. Cognition. So there are many mental state examinations. I think this is the commonest used, and this is to assess how much impairment of their cognition that they have. So how do we assess who gives them the medication? Because if someone is forgetful, they may take morphine and take it again in 2 hours. Who is the caregiver or the person who's sitting with the family? Who usually will be able to act as the proxy for the patient if they cannot be able to talk to you? Do they have delirium, or how do we prevent for that? And then if we find that someone has a problem, how do we refer this to somebody else who can be able to assess the patient and manage the patient accordingly? In terms of the psychological, I think we have to assess in terms of depression and anxiety. And I know in our healthcare system, that has not been integrated, where we assess how are you doing in terms of your anxiety levels. Do we even score it? For now, we are doing pain very well, but we have a way of assessing their distress. Like, how do you feel in terms of your diagnosis? Where are you in terms of your treatments? And we also assess for the risk of depression. Interestingly, older people have lower rates of suicide, but they have higher rates of depression. And you'll find older people, because of whatever is going on, they refuse to eat. And that's the commonest thing. So if we don't identify who is at risk, then we may miss these patients who already are going through life-changing events, but they also have other issues that are compounding to that. In terms of nutrition, we always use the body mass index, and I think it's commonplace that if you go to any oncology unit, you get a BMI. We usually look at the body surface area, but the BMI in terms of your weight and height. Any patient who's had an intentional weight loss for the last 6 months, sometimes you associate that to the malignancy itself, but it may to do with who is looking after this patient, who is feeding the patient, what is their dental health, do they have dentures, do they have someone who's preparing for the food? And that can be something as simple as just taking that nutritional history or sitting with somebody, and then we assess who actually is at higher risk of getting malnutrition. And because of the factors that I highlighted before, our older patients actually are. In terms of polypharmacy, we know that because you've been, around, your grandmother always had a recipe or something to help with a headache. So they always have over-the-counter medication. And this gets even more complicated for patients who have comorbidities. Someone will come and tell you, I've had diabetes for 10 years, I've had hypertension, I've had high cholesterol, I've also had a clot in my leg. So when you look at their medicine, they actually have a whole bag full of medicine. So we need to reconcile this medication with both the patient and the caregiver. And what needs to be discontinued is discontinued, because even in oncology, we will keep adding more medication to that bag. And you may find that you have a lot of drug disease interactions that we may need to pick up when you're assessing this patient. Now, coming back home after we talked about all these ideal things, is that in our clinic reviews, most elderly patients will come and they have symptoms that may not even make sense. My toe hurts, my head hurts. So we call them hapa na pale. But actually, if we sat down to actually assess, there may be something that we could explain for that hapa na pale. Ageism is where now you think Shosho is 84. What exactly are we doing here? Why don't we let Shosho? She's had a good life, let her, go on. And reverse ageism is where now the older patient come and find a young intern who's 24 and they have a lump in the breast. But they're like, this is not even my child, it's my grandchild. How will they examine me? And this is something that within our healthcare system, we always have to be cognizant about, whether you call an older physician or an older nurse to chaperone you, so they can feel comfortable, especially for the younger physicians. And I find maybe that might be the gap where we are missing a lot of patients in our clinics, because they see huyu ni mtoto wangu. We always find the cancer of the cervix patients because they'll have a discharge. For most women, they've gone through menopause, they start bleeding again. It is to them embarrassing, and they can't come to you and tell you that there's blood coming out. So these patients end up staying for quite a long time before they come to a hospital, and it's all to do with the doctors are too young, or I want someone who's older. Again, we have a lack of a dedicated geriatric service, and I think this is where now our healthcare system is not catered for the older person. I find that sometimes in some of the clinics, you don't even have a ramp for a wheelchair to go in, which might be a problem, but for the older person, they are not really on a wheelchair. They just need a ramp to walk up, and they can be able to walk up because the stairs may give them a problem. So do we think about our older patients, or we think about the one who's wheelchair bound, on a stretcher? Or if you find you've sent an elderly gentleman to the lab and he's taking forever, you quickly tell him, please, can I give you a wheelchair? They don't want, they still want to keep their independence, and we have to respect them for that. Again, this service of polypharmacy. In KNH, I know they've done this very well in the main pharmacy, where they can go and reconcile all your drugs. However, it's not a service that is offered to everybody. And once we build up to running our geriatric services, then this can be a service that is provided for at least reconciliation, assessing for drug disease interactions. And of course, the cultural aspects. I think we have to move away from thinking that you're too old to have treatment. There is nothing that like too old. We have to assess every patient on their own merit. What other comorbidities do they have? Do they have cognitive dysfunction? What is their life expectancy? Because then that has to factor when we are looking at cancer treatment. Patient has lived a good life. And of course, the big one is everyone, no, chemotherapy is bad, radiotherapy is bad, but the side effects are not too much because someone is old. We have to assess every patient on merit. So we need to have an awareness that there is a big concept called geriatric oncology. If you look at any of the publications, they'll say the older person living with cancer. And again, when we think about it, we are all, as JP said, we are all headed there. So when we get to 55 or 65, then we'll be the older person. And if we actually do get cancer, we have to be aware of the comprehensive geriatric assessment. And as you can see, it's a detailed thing to look at the patient. It's not just your 1 hour assessment. We will need to avoid generalization so that we stop saying that, no, that person is old, or someone needs a mastectomy, they can't have it, or someone needs a gastrectomy, they can't have it, because it's an older patient. And we have to individualize care, which is where we are in terms of oncology. Now, the issues that we have, I think for our general public is the one, we have an issue with lack of awareness. And this can be both to the general public and also to the clinicians, that if someone is old, don't write them off. Or if I am a lady and I get a lump in my breast at 70, that does not mean there's something wrong. There might actually be something wrong to look at. Our patients are presenting late, and I don't think the issue with this is that when they go to the clinic, because of either reverse ageism, they will refuse an examination, or they don't see that there's a problem. And they always see the younger clinicians as my children. I'll have older people who come and they look at you first and they're like, are you sure you're the doctor? But you have to, again, gain their confidence in terms of, I am here to treat you. Don't see me as your child, I'm here as a doctor, because that might make a difference for some of the patients who may not report some of the issues. Again, because our patients are older, most of the screening guidelines, like for breast, they push it up all the way to 70, 75. So if someone is older than that, they may not even fit the screening guidelines. Same for cancer of the cervix. But you find we're diagnosing cancers, like a lady I saw today who's 84 years old and has cancer of the cervix. So she was out of what is the recommended screening area. And those, again, I think is a select group of patients that we need to think about when they go to the clinician, what are the cancers that we should be looking out for, because they might be missed. And then thinking about ageism, that this generalization that our patients are older, so they cannot get chemo, they cannot get radiotherapy, we will need to move away from that. And of course, we have socioeconomic challenges. So you find for elderly patients, they're relying on a pension, or their NHIF has run out, it's not been working, they have no other insurance, their children are not paying for their care. And those are some of the issues that I think end up with having many of our older patients passing on, not because of the cancer itself per se, but maybe because of other social and economic reasons. So there's an 83-year-old lady that I met from Nyeri, who was from Karatina, and she was a para 6+0. She had hypertension, and she was being worked up for coronary heart failure. So at that time when she was seen, she had a mass in the right breast and she had pelvic pain, and she reported that this had been there for about 6 months. On the local examination, she had what looked like a clinical T4C, which is just an ulcerated breast. She had mobile axillary nodes, and there was a little skin nodule on the lateral side of the chest wall. A biopsy had been done of that breast mass, and it showed an invasive ductal carcinoma that was grade 3, estrogen receptor positive, progesterone receptor positive, HER2 negative. And this just means that we've confirmed there's a cancer of the breast, and it is hormone receptor positive, which is the estrogen receptor and progesterone receptor. She was again noted to have a HB of 7.6 and had 3 units transfused immediately. That is her biopsy, and that was what was found at that point in time. Now, she had CT scans, and I've put arrows here, so you can see that there's a mass in her breast. Same mass here, and as you can see, it's actually in both the skin and ulcerated right through. Her CT of the pelvis, you can see on her right iliac bone, again, there's a destructive lytic lesion there, same with there, and it continues all the way down. So in her blood test, she had a corrected calcium of 2.1. This is important for patients who have a bone lesion, because they may actually have hypercalcemia, which is one of the medical emergencies that we talked about. One of her kidney function, her liver functions are within normal, and we ordered a tumor marker called CA15-3, which is important for prognosticating patients who have metastatic disease. And this is the picture. And I think, just to highlight that this is, again, an 83-year-old woman. So by the time this mass gets here, so even with that history of 6 months, I doubt that this was there for 6 months. It might have been there for longer. But then by the time it got to this point, this lady has actually been struggling. She was in pain. The mass, of course, was bleeding. It was smelling. And there was this little nodule on the chest wall. So as I conclude, for like that older patient, we need to be aware that we need to have a high index of suspicion. When these patients come to the hospital for any reason, let's examine them. Let's talk to them about examining, because you may be able to pick up some of the lesions that they have. We need to be aware that we have a growing aging population. I think in the US, they predict that 70% of cancer patients by 2030 will actually be patients who are older than 65. And as I highlighted, again, the majority of patients not included in clinical trials. So we do actually may not have the whole picture in terms of the therapies that we're instituting for patients. There is need to look at that comprehensive geriatric assessment, as detailed as it is. I think it may make the difference for some of the treatments that we're having. And we must think of a multidisciplinary approach when we are managing the older cancer patients. Thank you very much.
Wow. Wow. A wonderful presentation, right? And I personally have learned a lot from the presentation, and I would like to invite you just write in the chat one thing, and that is, what one thing have you learned or been reminded about today? What one thing? Okay, I'll allow you to write even two. But what two things have you learned or been reminded about today? I would like us to just reflect briefly so that we can internalize this as we prepare for the next presentation. Yes, Lillian says, a wonderful presentation. Indeed it was. And what one thing have you learned today? What one thing have you learned today that you will take with you from this presentation? As you write that, I would like to invite Dr. Andrew Odhiambo, who is our next facilitator for the next session. And I'll introduce Dr. Andrew briefly. Many of you may know him or might have interacted with him, some of you. Dr. Andrew Odhiambo is a program director and lecturer for medical oncology at the University of Nairobi. He's a consultant physician and a medical oncologist at Prime Care Clinic and at Nairobi Hospital. His background is that he has an undergraduate degree in Bachelor of Medicine and Surgery from University of Nairobi, and an M.Med, Internal Medicine from University of Nairobi, and is also a fellow. He's done a fellowship in medical oncology in the UK. Dr. Andrew is passionate about cancer awareness, and also he was awarded Business Daily Top 40 Under 40 in 2017. You can read more about and engage more with Dr. Andrew on his website. I will put it on the chat, but it is drandrewodhiambo.com. He does a lot of cancer awareness things, and he's a member also of the National Technical Working Group for Cancer Prevention and Early Detection, which we coordinate at the National Cancer Control Program. I will sample a few of your reflections after when we go to the Q&A session. So please save your questions, and we are looking forward to a very vibrant Q&A session. Thank you, and karibu sana, Dr. Andrew.
Thanks, Dr. Bor. I hope I can be heard clearly and my slides are visible on slideshow mode. Is that correct?
Yes, and we can hear you very clearly. Thank you.
Okay. So I think thanks, Dr. Njoki, for making my work much more lighter. In fact, I've deleted like 20 of my slides because I think we were referring to the same guidelines about comprehensive geriatric assessment and so on. So I'll try not to repeat what has been said, and possibly spend more time sharing experiences about managing elderly patients with cancer. So the next slide. So I have no conflicts and my views are my own. So I'd like us to pause and take a look at this picture and analyze it very clearly. And probably if you're going to forget anything today, let this be one of the things that you don't forget. When you're dealing with cancer, chronological age cannot be equal to physiological age. You can see a patient who is 90 years old on the file, but when they walk into the room, the patient looks vibrant, looks healthy, looks very robust. You know, a patient will tell you he walks 5 kilometers every morning. He rides, I don't know how many kilometers on the weekends. He's running his petrol station. He's working 6 days a week. And this is somebody who is 90 years old. Whereas you can also have somebody who, you know, comes in and is 50 years old, but physiologically, the patient has used alcohol for about 50 years, has smoked, has got cardiac issues, has got renal issues. So that person, despite the fact that they may be young and they don't meet the criteria for being labeled an elderly person, they will have issues undergoing cancer treatment because physiologically they are older than they seem. I won't spend so much time on what Dr. Njoki has already talked about, but just as a means of introduction, managing the elderly patient with cancer is becoming more of a problem, and Dr. Bor has already said the population that is aging is increasing, and Africa is getting ready for this. 2 decades ago, HIV was quite rampant and many people died. So the number of old people that time was less. But now that HIV has been controlled, more and more people are living longer and many of them are getting cancer. And remember, age alone is one of the single most important risk factors for developing cancer. So we will have very many old patients, but as I've said, these old patients, they are a heterogeneous group. They are not all the same. You can have strong, fit old people, and you can have old people who are significantly frail, they are impaired, they have cognitive issues, as Dr. Njoki has said, they have comorbidities, they can't hear, they can't see, and they are all in the same age group. So you as the doctor, you have to devise a way in which you can carefully select who amongst this group is likely to benefit more from the treatment, is likely to go through the treatment without toxicity, and is likely to have a better outcome because we can't all treat them the same. You know, a 20-year-old with Hodgkin's and another 20-year-old with Hodgkin's, they'll all be the same unless somebody has got serious issues from childbirth, but they'll relatively be the same as far as their homogeneity is concerned. But the elderly person, as I've said, you can have 2 90-year-olds who are in different worlds apart, and it is the doctor's duty to find out who is the fitter one and who can I consider for full treatment, who can I consider for abbreviated or dose-adjusted treatment, or who can I consider for only best supportive care and sort of a tailored palliative care approach, and not take them through the gruesome treatment and expose them to a lot of side effects. And we shall be seeing some examples about this later on. Dr. Njoki has already talked about the attitude of caregivers towards their parents, and they'll come and tell you, doctor, my mom is too old for chemotherapy. Chemotherapy is a thing that is for young people, it is not for old people. And sometimes it's really a hard choice for the oncologist to make sometimes, because as much as we want to offer treatment, we also have to spend a lot of time explaining to the relatives that we only don't look at age, we look at other factors, and we also have to weigh the risk and benefits of treatment. Survival has already been touched on, prognosis and how much longer you're going to live, and what is the benefit of taking somebody through surgery, through chemo, when actually they have exceeded their life expectancy. But life is life. If that person was to make the decision for themselves, they would want to live 1 more year. You know, African families always want to try something and try everything and not leave their parents, you know, just to best supportive care. But sometimes you have to draw the line and tell them, you know, treatment for pancreatic cancer is not a joke. You either go full force and give the full dose chemotherapy, or you do nothing, because some of the other treatments can have a lot of side effects and then they don't end up even helping the patient. There are a lot of myths and misconceptions. Fear of treatment is there. And remember, for the old patient with cancer, you have to choose quality over longevity. Somebody would rather have 1 year of a good quality life. Maybe they are taking oral chemotherapy or targeted therapy, and they're able to live life with good quality. It may not be so much longer, but their quality in good. But for a young patient, you know, you have to maximize on longevity over quality. That's why even patients with acute leukemia, patients with high-grade lymphomas who are young, we have to give them high-dose chemotherapy. They have to go through a lot of toxicity in order to have a longer life. So these are some of the things we need to look for when we are managing these patients. This concept of ageism has already been touched upon, so I won't dwell much upon it. But from an ethical point of view, we are supposed to do no harm, especially when the harm doing comes at a cost, because now we have very expensive treatments that cost in excess of $5,000 per month, and you have to really justify whether giving this elderly population this treatment is really meaningful to them The average African family, can't afford $5,000 every month. So it's not worthwhile having families selling their property, removing the children from school in order to pay for these expensive treatments that in the end do not make a big difference. But something I'd like to point out is in some cancers, the elderly have just as good outcomes as the young. So we need to give them that living chance. Just because somebody is 81 years old with a diffuse large B-cell lymphoma does not mean that they cannot get full treatment. Take them through the screening, do their comprehensive geriatric assessment, give them a score, and if the score is good and you feel they can go through the full treatment, then give them the full treatment, support them through the treatment so that they can get through it, so that they have a high chance of survival in some of these curable conditions. Breast cancer, colon cancer, also some other examples where the elderly need to be given as good a fighting chance as the young. And also in the era of targeted therapy, tyrosine kinase inhibitors, immunotherapy with relatively low toxicity, we have to consider giving these patients the best fighting chance. So definitions have been touched upon. I'll not spend so much time on it, but generally there's no consensus. The International Society of Geriatric Oncology puts it at 70. Many of the USA guidelines put it at 65, and this is mostly for insurance purposes, but I will not spend more time on this. These ones have already been dealt on. I'll talk about frailty just for a little bit, and this is the concept of trying to find out among the large heterogeneous group of elderly patients, who is the one who has the most problems that can be the most challenging to the healthcare system and the professionals. Those are the ones we want to single out and put them aside, because putting them through treatment will result in adverse outcomes, will result in mortality, morbidity, toxicity, admissions into hospital. So that's the whole point of having the screening models, which Dr. Njoki has very well gone through. So I'll not repeat them, but this is just an algorithm. If somebody comes to clinic and they're more than 70, if they look healthy or they look good, they look good to you externally, they need a quick screen, and there are various screening tools. If the screening tool is negative, treat this person as you would treat a 45-year-old. If they have a positive screen, then you need to subject them to a comprehensive geriatric assessment. And if they score well, they can go back to the full treatment group, or if they have a poor score, then they become more in the vulnerable group and they need customized treatment. Those obviously who look very frail, they still need an assessment to capture a lot of the issues Dr. Njoki talked about, polypharmacy, nutritional issues. And if they are frail, then they need to have just supportive care, because trying to take these patients through 6 months of chemotherapy, you would wonder what you are trying to achieve. So what do you consider? Generally, as has been mentioned, elderly people have low social support. The whole issue of finance, medical financing, insurance, insurance will not take you into their scheme if you are 80 years old. They'll tell you our cap is 65. So if you're not 65, go home. And low social support has been associated with worse outcomes. So having the social workers involved is very important. The home environment of an elderly person, we can talk about this for ages, but there are many things that need to be addressed here. I'll just give you, like, two of my patients in the last 1 month have had significant falls at home. There's a guy who actually banged his head so hard he had to go to A&E to be stitched up. And this is an elderly patient who is actually undergoing chemotherapy, but his home environment has not been adequately assessed for the risk of falls. And this sometimes can be dangerous for patients and can result in unwanted injuries. The issues of disability have been touched upon. Where these patients are seeking treatment, is there access, is there wheelchair access, or they have to climb stairs like the rest of us. So those are some of the many issues which we need to consider. As far as surgery is concerned, many Kenyans will say, "Doctor, my dad is too old for surgery. He will not wake up, And when you cut the tumor, Will the cancer spread? Sorry, I think people need to mute. Sorry. So there are a lot of surgical myths, and I don't want to spend so much time here, but basically, many people fear surgery, and the fact that somebody is older, they fear it even more, and they imagine that it's impossible even for 75-year-olds to have cancer surgery, which is not really the case. Surgical risk is not linked to chronological age alone. Consider other factors, and all these are captured in the comprehensive geriatric assessment. And there's a whole verification program with the American College of Surgeons, which verifies the geriatric population prior to surgery, as well as there are many other risk calculators. So can all people go for surgery? The answer is yes, but they have to be carefully selected. As far as chemotherapy and systemic therapy is concerned, again, you have to weigh benefit versus risk. Am I going to give you 6 months of chemotherapy that has a high risk of neutropenia, high risk of DVT, high risk of all manner of complications? In order for me to increase your survival from 6 to 9 months, is it worth all the risk? Probably not. But if the benefit could be a possible cure, patients with Hodgkin's lymphoma, patients with non-Hodgkin's lymphoma, we still can cure even the elderly, even who have stage 4 disease with chemotherapy. And we have done it before, and we are continuing to do it. So there the benefit is more than the risk. Look at the other demographics, look at the body mass index, look at other anthropometric measurements, and assess this patient carefully. Surprisingly, genitourinary cancers and GI cancers have got the highest risk of toxicity when it comes to chemotherapy. Patients who have cancers in the stomach already have got poor eating, they are undernourished, they have a higher risk of getting post-chemotherapy nausea and vomiting. So you really have to weigh the risk and the benefit and really support these patients throughout the treatment. Diarrhea is a common side effect of many of the GI chemotherapy protocols. So we have to protect our patients against this diarrhea. The issue of using one chemotherapy versus many chemotherapy drugs, we also have to think about it. When you are palliating these patients and just palliating their symptoms, using one drug sometimes can do the trick, so you don't have to expose them to multiple drugs at the same time. There's a common drug that we use quite a lot called capecitabine, commonly marketed as Xeloda, which we commonly use for treating many types of cancers, from breast cancer, GI, colorectal cancers, pancreatic cancers, and we use it a lot in maintenance and palliation. But this drug, if that elderly patient is not educated well enough or lacks capacity or has memory issues, you have to be very careful. We have had patients who have taken the wrong dose, who have overdosed, have underdosed. Sometimes they take double the dose, and we always have to tell their children and caregivers they have to take this tablet how many times in the morning, how many times in the evening, and we even encourage them to have the pill containers that have the number of pills they take in the morning and evening clearly outlined. This tablet looks very much alike to esomeprazole, so you can actually confuse it sometimes. And you find patients are now taking the esomeprazole and imagining they are taking Xeloda. Sometimes, if this is not done well, then it can actually affect the outcome. As far as laboratory values are concerned, patients with elevated creatinine, which is very common in the elderly, you have to really dose adjust your treatment according to the creatinine clearance and not just the serum creatinine that you do. You have to calculate the estimated eGFR and dose your chemotherapy according to it. The elderly are at a higher risk of getting neutropenia. So if you're using polychemotherapy, then it is encouraged to give them prophylactic G-CSF so that they don't run the risk of getting neutropenic sepsis. If you get an elderly patient with full-blown neutropenic sepsis, their chance of mortality is in excess of 70 to 80%. So you'd rather not get there and give them prophylaxis. Elderly patients also have a higher incidence of anemia due to many other reasons, and the fact that now you're giving them carboplatin, cyclophosphamide, they even have a higher chance of having their hemoglobin dropping. So you really have to choose less myelosuppressive chemotherapies. You can support them sometimes with erythropoietin if they need. You have to keep checking their blood tests and give them transfusions when they need. In fact, I've just seen a patient just a few hours ago who had her chemotherapy last week, and now the hemoglobin is 7. So you really have to be careful about that. And then also liver functions. All these organ functions deteriorate with age, and they require frequent monitoring so that we don't run into problems. I've already talked about functional status and the risk of falls. Hearing and vision has also been touched on, so I won't spend so much time on that. A few other pointers as far as reducing toxicity. The elderly patient, they need to have some Imodiums in the house to be wary of diarrhea, and they also need to be hydrated more, probably a little more than you would for a younger patient. Let them have laxatives at home so that you can cater for the constipation. They're at a higher risk of mucositis, so sometimes early initiation of parenteral nutrition is good. I've already talked about bone marrow suppression. Neurotoxicity is a big problem in the elderly. The elderly is at a higher risk of getting neuropathy, cerebellar issues. So you really have to monitor hearing, peripheral neuropathy. Sometimes they won't be able to report so well, and I'll give you a case study on this on one of the patients. I've already talked about falls. Be wary of cardiotoxicity. It is much more common in the elderly, especially if they have comorbidities, which most of them have: diabetes, hypertension, cardiometabolic syndrome, high cholesterol. So work together with the cardiologist, screen them for these cardiac issues, do echoes on them, do these evaluations every 3 months so that you don't send patients into symptomatic heart failure and cause more problems than you actually found them to have. I've already talked about renal issues. And then as far as insomnia is concerned, be very careful with the benzodiazepine. Just giving them like Lexotanil or diazepam or Domicam without being very careful can send patients to the A&E in coma or excessive sedation. So probably use other natural methods, chamomile tea, melatonin, or the non-sedating antihistamines can help with insomnia in the elderly. This slide has been touched on extensively, and I know it will be covered in a separate meeting. But remember, communicating with the older patient is not the same as you would in the younger patient. You really have to ensure that the message has gone in and the patient has understood what you are telling them, because poor communication results in a lot of problems, and I will show you a case that really shows what I'm talking about. So this gentleman is 84 years old this year. He was diagnosed to have stomach cancer more than a year ago in August 2020. And obviously the presentation was late because these old mzes, they hardly complain. They feel like it is their right to suffer, and when they're having pain or any symptoms and they're supposed to be the men or the leaders of the homestead, they're not allowed to be sick. And anytime somebody with stomach cancer goes to hospital, the first thing they're treated for is worms, amoebiasis, typhoid, H. pylori, brucella. The list is extremely long. But eventually he was found to have a stomach cancer. So despite his old age, he did have surgery, and he had a successful surgery, and he had an uneventful recovery. Though the cancer was advanced at the time of gastrectomy, he went through it well with no healing complications, no leaks, and was out of hospital within 2 weeks of the surgery. The post-surgical recovery at home took some time, but eventually he was able to present for chemotherapy, and because he had high-risk disease, we discussed the risk versus the benefit. And we sat down with the children and we talked and we talked and we talked. And I told them, if your dad has withstood a gastrectomy and a Roux-en-Y anastomosis, then there's a high chance that he'll respond to chemotherapy with Zelox, which is a very common combination we use for GI cancers. It's not the ideal for gastric cancer, but in somebody his age, it will be acceptable. He did undergo 8 cycles of chemotherapy. But what we noticed midway is that there was poor understanding about one of the common side effects of capecitabine, and this was hand and foot syndrome. And there was also poor communication about the understanding of another complication of oxaliplatin, which is peripheral neuropathy. So every time this Mzee would come to the cancer center, I would see him. I would ask him, how are you feeling? Are you having any numbness? Are you having any feeling of the hands and feet? And he would say, no, I'm feeling maybe a little numb, maybe 1 or 2 days after the chemo, but then after that, it would reduce. So I made a habit of asking him this every other time. But what was missed was that sometimes in between his cycles, he would complain of symptoms of neuropathy, but there was nobody to report to where he stays. As is with these elderly people who do not like staying in the city, as soon as his chemo is done, he's back in his rural home where he's either alone with a helper, probably the helper also has a language barrier, or it's somebody who is very young and there's a very huge age gap between these elderly patients and their carers. So there was poor channeling of communication from him to the helper, to the children, to me. So after the 7th cycle of chemotherapy, he developed grade 4 hand and foot syndrome. And you can see here his hands have completely peeled. And this is a common side effect of capecitabine. This we had not noticed throughout his first 7 cycles. And whenever you get this grade 4 hand and foot syndrome, this sort of even makes the peripheral neuropathy worse. So he required hospital admission, he required wound care to see him, he required occupational therapy to come and put splints, he required IV antibiotics, and he was in hospital for almost a month. This was about 2 weeks later, and here you can see he has improved about a month after being in the ward, and this was after finishing all his chemotherapy, and you can see he improved. But he has significant impairment in bending his fingers and hands. All his fingerprints have been wiped out. He can no longer even use biometrics, even if he wanted to. But now he has significant grade 3 to 4 peripheral neuropathy. He can't feel his fingers and his toes at all. He feels like he's walking on ice. He can't feel the sole of his shoe, but he's able to get by. For about 2 months, he wasn't even able to walk. But this was him just this week in the clinic, completely healed. He was able to walk. Even his legs had completely healed, and but previously they were completely peeled. So this just goes to show you, even if it's possible to take patients through this treatment, he's one of the few who suffered severe toxicity, which I think could have been prevented if there was proper communication from him to his helper, to his children, to us, so that we could either reduce his number of cycles or reduce his dosage or even omit the offending agent. It's another example of how just the elderly people present. This patient, we saw her in Kenyatta several years ago, and she had this florid lymphadenopathy for 2 years, and she was just, in the village. They were painless, going on with life. And when the children went to visit her for Christmas, they were shocked, utterly shocked when she removed, they cover themselves with scarves and things. And when she removed the scarf, the children were shocked. They were like, "Mom, what are these? You mean you've had these things for 2 years?" So, we should probably be visiting our grandmothers more often, so maybe we can catch some of these things early. But to cut the long story short, she was diagnosed with chronic lymphocytic leukemia, and she was able to receive treatment, and she got better. This elderly man, I saw him many years back, I think in 2015, an old man from Garissa. Again, issues of late presentation. You can't tell me this guy has never been to hospital. He had a squamous cell carcinoma of the anterior left maxilla, which eroded into his upper jaw and eroded his entire upper jaw, and was almost even wanting to erode to go into the orbit. This man, we saw him, we discussed with him the treatment options. He was told about toxicity, he was told about everything. He He had a lot of insight. He had good capacity. He understood everything, but he said, no, he does not want any of that. He can eat. He can chew his tobacco. He can take care of his cows, so we should not bother him. And he went back home. And there are very many other cases of patients who are quite elderly who we've taken through, treatments that would have otherwise thought to be not possible in them. We've shared a 74-year-old male who had colon cancer with metastasis to the liver, and he successfully had a stage 3 section of both the colon cancer and the liver metastasis, and is well up to now. We have done mastectomies in even 90-year-old patients, followed by hormonal therapy. We have treated patients with triple negative breast cancer who are 74, 75 and above, just as we would a young patient. Mastectomy followed by 6 months of chemotherapy, followed by radiotherapy, and they have done well. There are also patients who, they refuse treatment. We had an 85-year-old patient with colon cancer. She refused chemotherapy. That was a year ago. Now, sadly, she has breast cancer, and all of a sudden, the family now they want chemotherapy. But these are some of the challenges we get. We have treated patients with esophageal cancer, quite advanced with chemotherapy, and they have gotten good palliation. The esophagus has opened up. They have good swallowing, and they have better quality of life, better than patients who even have been given stents, which cause a lot of pain. And really, the examples can be more and more, but I think it's time we move over to the take-home points, and maybe we can have a discussion. So elderly patients, as I've said, they're heterogeneous. They have a high risk of mortality and toxicity. So we really have to select in this heterogeneous group of old people, who are the ones who can benefit, who are the ones who can go through this treatment, and who are the ones who cannot. Because that is the big question. That is the elephant in the room. We should be able to screen them using the assessment tools so that we can know who can be given a chance. Those who can be given a chance, let's give them the chance. Let us support them through the treatment. As much as they may have more toxicity, we now have good medicines to manage all this toxicity and to follow them up closely so that they go through the treatment as well as they should. And obviously, risk and benefit should always be the overarching principle, so that we are not just giving people chemo, taking them for surgery, and they're having bad outcomes, they're having premature deaths, all in the name of trying to give them the best. Thank you very much.
Wow. Wonderful, wonderful presentation, wouldn't you say? I think you'll agree with me. We have learned a lot this evening. And once again, I want to give you just 30 seconds to reflect on what we have learned from Dr. Andrew. What have you learned? One or two things you have learned, or one or two things you have been reminded of in this session. Just write it in the chat. I'm just giving you a few seconds to do that. In as few words as possible, you can just write one thing you have learned today in Dr. Andrew's presentation, or what has stood out for you. They usually say that the real conversation usually happens after the awkward silence in the conversation. So I don't mind awkward silence. I want the real conversation. 10 more seconds.
Aisha, ilendaje?
Kindly mute yourself. Thank you. And I want to pick up a few of the comments from the first presentation by Dr. Njoki, whose focus was on clinical presentation and diagnosis of cancer among the elderly. And it seems that like a big take home from that presentation was on comprehensive geriatric assessment. The element of a holistic approach and a multidisciplinary approach stood out for most of you. And another thing that came out was the need for having a high index of suspicion, being sensitive to the older persons and to their assessments, being proactive as health workers, being more concerned about the older persons. Another thing is the urgent need to address the health needs of older persons. In fact, one person, Josiah, observed that care for the old is missing. So we are the ones who need to do something about this. Somebody else observed the importance of teach backs, another one, the poor representation of older persons in research or even in trials. And another one of us identified that there is a need for training in geriatric specialties and that the Ministry of Health should be able to do something about that. I know that the head of division of geriatrics, Dr. Modoni Gichu, is here. She has had. Another thing that stood out is ageism, but then there was comment by Warui, which I would like to invite Dr. Njoki to comment on. And the comment by Lydia Warui was about palliative care and home-based care being more ideal for older persons. What would you say about that, Dr. Njoki? And there was also another question that I think Mogaka is the one who asked, what is elder speak? You had referred to that earlier, so maybe you can address those two.
Okay, so I'll start with Waroi's question, and I think it's important to also talk about this. Again, palliative care is not something that is just for older patients. I think they have more needs that we need to address that could be addressed through the principles of palliative care. But what I think we are missing is home-based care, or how do I say, home-based care in terms of, have we kitted out their access to the house? Have we kitted out that their bathrooms, they have anti-sleep mats, they have guardrails? Do we have beds that can assist them to get out of bed so that they can be more independent rather than being dependent? Because I worry that sometimes we end up admitting our older patients not because they really need to be in hospital, but there may not be somebody to sit with them at home. They need diaper change, they need a nurse, or they need home-based care treatment. And that may not necessarily be care that they need in the hospital. It may be a transition to get into home, or who actually give this home-based care. Of course, palliative care plays a bigger role because then they might have a bigger reach in terms of that access to patients' home or being able to visit them at home. That is very different from the hospital. Elder speak, what we're talking about is when we try, it's called also infantilization, or trying to talk to old people like they are children. So it's seen a lot in patients who are managed for dementia, where you start talking to them in slow, loud, very short sentences because we think they cannot understand. But this, for patients, I think for patients who do not have any issues with dementia, it's quite irritating, and you might find they actually cut off and they don't want to talk to you because they think you are insulting their intelligence, which to some extent may feel like that because they can hear you very well, but you're trying to talk to them like they can't understand what you're saying. Thank you.
Thank you very much, Njoki. That's a great response. I'm also looking now at the comments that we have made concerning the second presentation, which was by Dr. Andrew, and it was about focusing more on the special considerations for treatment of cancer among older people. And it looks like some of the things that stood out for us is the issue of chronological age versus physiological age. That for me was also a very important take home. And I think it's something that we can all actually implement for ourselves to manage our age so that, you know, we have some control on that, right? And the other things that came up that were highlighted, the assessment tree and the treatment strategy for older people, the toxicity consideration. And there is a question that somebody has asked. They have requested that you comment, Dr. Andrew, you can comment on the issue of relatives and caregivers wishing to withhold the knowledge of the cancer diagnosis from the client. What do you think of that? And how you know, comment on that? How do you handle it? Have you seen it? Yeah.
So thanks and thanks for the participant who asked that question. I'm in that situation nearly every day, and I take each context differently. So I'll give you an example. If maybe you're seeing a patient who's got hepatocellular carcinoma, the guy is 85 years old, the cancer is quite advanced, you don't give him maybe more than 2 months, he doesn't qualify for any active anti-cancer therapy. Probably he's just going to be somebody for best supportive care. Whether you tell that patient you have advanced hepatocellular carcinoma or not, you'll not have changed. Maybe they can mute. I was saying for such a patient, knowing their diagnosis in detail, it doesn't add any benefit for them. So at some point, I would agree with keeping the information from him, or at least giving him a lighter version of the diagnosis. So you can say, Baba, you have a liver growth and there's not so much we can do. We'll just give you painkillers and 1, 2, 3, 4, 5. But if you turn the coin, and this is a cancer that is highly curable, this is a cancer where the patient can qualify for treatment, then it is not ethical to withhold the information from that patient. There's a way in which you can tell an old person they have cancer without rubbing it in their face and without telling them the gravity of the situation, especially if they have some elements of spread. If a patient has got 2, lung nodules that he doesn't even know about, he can't even feel them, but they are there on the CT scan and they are metastases. Does he need to know that he has lung metastasis? Maybe no, but you can tell him you have breast cancer. Yes, we're going to treat it. The lung metastasis, we'll keep it to me and the children. So every context is different, and we must look at it from the African cultural point of view. These patients don't belong to the doctor. These patients are relatives of somebody. They are family members of somebody. Feelings are involved. So you have to look at each context individually. And especially when treatment is going to be offered, you can't offer somebody anti-cancer treatment and they have no idea what they are taking. That is unethical because the patient has to consent to the treatment. So there's no one answer for every situation. You have to look at the dynamics, look at the family issues around that patient, and tailor-make each decision for each patient as you see them. And the patients will always be grateful for what you're doing to them.
Wow.
And if I may add,
Yes.
just to agree with Andrew, that even as we try to individualize, is to remember that I think as oncologists, our primary responsibility is to the patient. And as he said, we do no harm, but sometimes the principles of doing no harm you may have, especially I find for children who maybe have not been actively involved in the care of their parents, then all of a sudden there's a diagnosis, the whole family is in crisis, and that might not be a consultation just for the patient. I find for the older patients, they tend to be more understanding. They rationalize their decision. I've had a good life, now I have this cancer. But you find that most of the patients that we struggle with talking about treatment is to do with the children. And that's where now you need to bring in a counselor, sort of delve into the social dynamics to figure out, it might be issues to do with finances, who's staying with the mother when they come to Nairobi because the mother never visits. It may be something as simple as who's going to pick the mother from Nanyuki for chemotherapy. And if we had enough time to now delve into those social dynamics, which integrating palliative care into the oncology clinic, getting a psychologist involved early, we may resolve some of these things of don't tell them what they have. Because if you tell them what they have, then the mother will go like, I need treatment. In the same breath, we also have families that have issues with economics. The older Shosho is the one who is the Miss Moneybags. So if we tell her she has cancer, we may be left out because we use all the money for the treatment of this old Shosho. So we actually have to actively sort of tease out some of these issues when we are doing the consultation. Thank you.
Wow, it's not a one fits all kind of answer. It's quite complicated, but I want to remind us that we shall have another webinar about communication to cancer patients and also another one on palliative care. So look out for the flyers. I saw Dr. Zipi's hand was up. Dr. Zipi, would you like to ask a question or comment? And also at this point, let me ask participants that if you have a question and you would like to ask, you can ask verbally. You can just raise the hand and then raise the virtual hand, and then we'll see. But Dr. Jonathan Thusi, I've seen your question, and I'll be asking one of the presenters to address it shortly. Maybe Joki and Andrew, you can look at the question in the chat, and you'll address it after this.
Okay,
Dr. Zipi?
I had some comments. Thank you very much, both presenters, really good presentations. I just wanted to comment when Dr. Jirani talked about home care, which is, I think the West is a lot well developed in terms of having homes that can take care of patients because they live in better places. Sometimes our homes are, visiting patients at home, if you do home visits, you'll understand what I mean. You go to a home and the patient is on the floor, it's a mud house, it's the toilet is, I don't know how many meters from that house. It's just, it's not a home that a patient can live in. Although studies that we've done show that patients love to stay at home. Everybody wants to be at home, to be taken care of by the family, to die within their, if they're dying, to die in familiar surroundings. And that is very important also because that's where that's where home is. But sometimes it's very difficult to keep these patients at home. If a patient has, for example, is bleeding too much, families cannot deal with some of these things. So one of the things that you lack in this country, and this is also back to the ministry, is facilities that can sometimes take these patients who need maybe emergency care or even just, how do I put it, care that is more comfortable than what might be at home. And so we lack things like home inpatient facilities or inpatient hospices when we actually could benefit from them. Although we advocate in palliative care, we advocate for patients to be taken care for, to be taken care at home because home is the best. Now, one of the things that you'll be talking about palliative care in the next session, I think it's just also good to emphasize that early palliative care is very important from the time of diagnosis because of the fact it's really improves the quality of life. It might even improve survival. Studies have shown that people who receive palliative care at an early stage might live longer than those who have not received. And also it deals with a lot of issues around death so that even if the patient is dying, maybe they're well prepared, they have done their unfinished businesses, and with what we call a good death. They have a good death, which is not pain-free, and maybe the symptoms have been well managed. In fact, people who have got good palliative care from the beginning have less distressful symptoms when they're dying. So I think there are many things that hopefully will be addressed in the next session for palliative care. But I think the most important thing for me I want to say here is there's no cancer care without palliative care. You cannot have a comprehensive cancer service unless you have integrated palliative care fully. And so it's very important that even as clinicians here, you involve your palliative care teams. Sometimes we leave them until the end when the patient is gasping, is when you're telling this people to come and help us, when you're calling us to help you. And really that is not fair for the patient. The patient needs all the care, not just the curative treatment, but alongside this curative treatment, we can help you manage symptoms, psychosocial support, and all those things. So please ensure that you have the palliative care teams involved from the very beginning, from the time of diagnosis. They're not coming to take over, they're coming to work alongside the oncologist to support the patient and to also deal with those many dimensions that the families have that you oncologists might not have time to deal with. Thank you.
Wow, great comments, Dr. Zipi. I've just been nodding my head off, and I'm looking forward to the session next week, where we'll be discussing more on palliative care. And thank you also for the resource documents that you have shared. in the chat. I hope the rest have been able to see it. So now I would like to ask Andrew to, Njoki, please address the question by Dr. Ndusi. And Andrew, there's a question I have forwarded to you that on the chat that I would like you to address. Njoki, have you found the question?
Okay, yeah. So I think
Maybe you can read
Jonathan,
it aloud and then
yeah, Jonathan
answer.
is asking when it has been assessed and concluded that the patient is too frail to benefit from treatment, issues of end-of-life care are bound to arise in this cohort of patients at times, with differences in interests of the patients or their families regarding initiation, withdrawing, or withholding the interventions in the best interest of the patients. And the question is, who handles these issues when they arise? So I'll piggyback on what Zippy said. I think there is no oncology care without integrating palliative care. And the reason I say that is, out of the few oncologists that we have in this country, they are mostly overstretched. Their clinics are full. We may not have a full hour and a half to sit and figure out what are the social dynamics, what are the economic dynamics that the patient may have, because then you're sort of time bound in terms of explaining, this is how the cancer started, these are the tests you are doing, this most probably will be the plan that you are going to institute for that one session that you have. And I think what usually happens, as Andrew explained, is that when we assess that patients are going to be for what we call, let's say, best supportive care, when we talk of patients who are too frail for treatment, they did not need anything. One of the most important things is that, one, you have explained that the path of treatment is going to be supportive care, which best supportive care means whatever you're giving is just to control the symptoms that the patient has. There are things like advanced directives, which are forms that are available in many of the hospitals that can be signed out. Thirdly, is to involve your spiritual counselor, whether it's an imam, it's a pastor, because patients may have other needs that they need to be addressed for them to make a forward plan. There are patients who you'll find when they come, like I had a patient who was a Jehovah Witness, had low HB and refused to have a transfusion. And the fight that we had before was, or the issues that were coming up were, one, my religion does not allow it. But the man, when he got to a point where he was now really unwell, we've done Venofer, that's not improving, he was like, I want to have a blood transfusion. And the conflict that he had was, my religion says this, but I need this treatment for me to feel better. So you find some of the issues that we have may be that we have a forward plan, and that you can institute with the palliative care specialist, the pain specialist, so that you have an agreement. What we always find conflict with is when the patient's wishes are different from what the family wants. Or as an oncologist, we have a patient, let's say with hepatocellular carcinoma, has ascites, he's having confusion, he's not feeding. His issues are very different in terms of sorting out the ascites, how do we feed him, reduce his risk of bleeding, while the family may want, no, there's this drug we've read about, can we start it, can we not? And you start to attempt, let's say the patient gets better and you start on a tablet called sorafenib. After a month, the patient has such severe side effects that you now want to withdraw, but they're like, if you withdraw, it means there's no treatment. So it is not a one-off conversation that you will have with the patient. It might be an ongoing conversation. For patients with an acute life-threatening condition, for example, they have hypercalcemia or they have brain mets, that assessment may be on a day-to-day basis. For patients who have, like, let's say, lung metastases that are on hormone treatment, it may be a review every 2 weeks when you start treatment so that you can see how the patient is doing. But you always have to assess as depending on how the patient is progressing. And of course, conversation with, remembering that as long as the patient is in good mental state, they still remain the primary person who should make that decision that is informed, because that's where the conflict comes about. There are some forms we have, I think in KNH, in KU, they already advanced directive forms which are already being used in the oncology units. And I think this can be referred to if needed for any other center. Thank you.
Thank you very much, Njoki. Very comprehensive answer. I hope, Jonathan, that answers you. It is now 3 minutes past our time, and I'm requesting your indulgence that we complete, addressing the questions that are there. And I'll invite Dr. Andrew to answer the question. And the question reads, does the treatment option change when underlying conditions are effectively managed? What are the proposed actions or thoughts around use of technology to monitor treatment process or toxicity outcomes? So those are two questions. Over to you, Andrew.
Thanks for those very important questions. So number one, I'll use a case to sort of answer that question. Many times when we get geriatric patients with cancer, they have a poor performance status. And in all patients, it's not only performance status, but we have to assess their geriatric capacity using the CGA tool. And sometimes we find patients are very frail, but there are some little maneuvers or little managements we can do to sort of make the patient better or fit for treatment. Do they have an underlying infection, maybe an undiagnosed UTI, or do they have a low hemoglobin, or do they have low albumin? So we can correct some of those underlying decisions. Is the diabetes poorly controlled? We can control some of those underlying conditions. And if somebody's frailty score improves, or the geriatric assessment improves and they are better, they are now walking unassisted, that's a patient who you can discuss the risks and benefits and see what treatment is suited for them. So yes, it is possible. Technology is here to stay, and I think tech is already being incorporated in a lot of these follow-up processes in the cancer care continuum. In the US, many cancer centers are now using it. Patients have an app they download and they put their profile. So their labs are in the app. They can report toxicities on the app, which can be registered or can be transmitted to their chemo nurses or their follow-up nurses in the hospital, and action can be instituted immediately. For us here, we just use WhatsApp. I think it's the best thing we can use. So I tell all my patients, when you get chemo, between now and the next chemo, don't just sit and suffer at home in silence. Tell us how you're feeling. Are you having numbness? Are you having nausea? Are you having insomnia? Are you having fever? Tell us. Don't even wait one more day. Tell us exactly how you're feeling. Don't wait for the neuropathy or hand and foot to get grade 4 to report. Tell us as soon as it is grade 1, then we can manage it faster. So WhatsApp is still technology, because previously, when there was no way for the doctor and the patient to communicate, then patients would have quite a grueling experience in between those 3 weeks from one chemo to the next. But now we are able to manage these patients through their treatment well, and they are able to get some toxicities early and actually intervene, and patients can be better. So technology is here to stay. There was something about death, resuscitation. As much as I know it will be covered in the palliative care session, I think if an elderly patient has the capacity, has the mental capacity, and has been assessed to have a proper mental capacity and can make that decision, then yes. However, in our setting, most of the time when we are signing DNRs, to be honest, the patient is not present due to extreme morbidity. So you'd find the patient is either in coma or headed there, or maybe has just 2 or 3 hours left before they exit. And so most of the time the patient is not present, but on few occasions we've sat with patients with pancreatic cancer, we've discussed, and they sign their DNR many months before they ever need to be in that situation, and we document it and we put it in place.
Okay, thank you, Dr. Andrew. I think we will take just one more question, on the, that we will address verbally. There's the question about the policy support. What policy support will make the practice of gero-oncology better? Maybe both of you can be thinking about that. I also just want to comment, to just read the comment by Dr. Njoki about the question that Kinyari has asked, that is it possible? The question is it possible to adopt a rapid geriatric assessment for a busy cancer clinic? And I think Dr. Njoki says, policy says that there are quick geriatric assessment tools online, which can be used in the clinic from the various oncology guidelines. This may need to be adapted for the various clinics in Kenya. So the last thing that we'll address is the policy, and then I'll invite the KENCO team to give some closing remarks, and we end the webinar. Over to you, Njoki and Andrew.
So I think policy is informed by one, clinical practice. What are the experiences that we've had in our country? And I think we've identified, as I said before, we've noted that for geriatric oncology or the young adults, they may have, we may not have developed policies specifically for those two groups. I think the formative stages of starting a policy or having a policy document would start with a discussion like this, and we've noted there's a gap. So then we sit down as the people who look after these patients, all the other interest groups that are there, because there are quite a number, to see what are the issues that we may need to address specifically. Because when you come up with a policy support, we must also think of how are we introducing this into the clinic, because again, majority of our patients fit the criteria for geriatric oncology, so that we can have a position on it in terms of policy as our country. Thank you.
Andrew, anything to add?
I think Dr. Njireni has pretty much summarized it. Maybe the only thing I can add is, if and when these policies are put on paper, then we must take them out of paper and put them on the ground. And I think that onus is on us. So the faster we get the policies drawn and take it from the book to the ground, then we'll begin to see a change in the kind of quality of contact our elderly patients are receiving. Thank you.
All right, thank you. Just one last comment from Gaudensia, which she takes an issue with mentioning specific spiritual faith as crossing professional boundaries. And I just want to say that, well, that is noted, and I'm sure it was not meant to pick on any particular, Dr. Njoki's comment was not really to pick on any particular group or faith, but to illustrate the challenges and the real life situations on the ground that we face. I hope you will pardon that. And so I want to invite Charles from KENCO Network to give any, administrative comments, and then we will be free to leave. Charles? Charles, you are muted. We can't hear you. We can hear you. We can see you speaking, but we can't hear. We still can't hear.
So I believe you can hear me now.
Yes.
Yeah, so thank you very much, everyone, for joining us today. And I would also wish to thank the facilitators for the presentations that were quite wonderful. And I think every one of us has learned a lot. So on the administrative side, we are going to be reimbursing the data budget in the course of next week. And I believe every one of us has put their number during the registration. So we will be reimbursing Kenya shillings 500 as we had agreed. So
where do you send the numbers?
Sorry?
Whom do we send the numbers?
I believe during the registration you had put your number. We had put it as a requirement.
It's part of the registration. Proceed, Charles. Charles, as you proceed, you're on mute. We can hear you now. Richard, your hand is up. just unmute and is it a clarification or is your hand raised by mistake? Richard Moema. Well, probably it's by mistake. Do you still have anything to add?
So I was just reminding everyone of our next webinar next
Yes.
week on that day from 3:30 to 4:30. So please plan to join us. We'll be looking at palliative care and end of life care for old cancer patients. So please plan to join us. Otherwise, thank you very much, everyone.
I want to end by thanking our presenters for today's session. Dr. Njoki, Dr. Andrew, fantastic job as always. Thank you very much. You've really opened our eyes to all these issues around managing cancer among older people. Thank you, all of you, for being here, for joining us. I think we can call it a day, and I wish you a nice evening and a good night. Bye-bye. See you next week.